Hello everyone, today we'll be talking about edema and why edema formation is so varied among tissues. This will help you figure out a few observations that you see on a daily basis. For example, why edema occurs more in leg, or things like you do get pleural effusion in hypoalbuminemia, but you have not seen any pulmonary edema in these patients. So let's understand some basic principle first before proceeding. This information is also helpful clinically because it helps you choose certain therapies. For example, if a patient has edema from cellulitis or inflammation, the edema will not decrease with Lasix or 5% albumin, but will rather respond to limb elevation. In the previous lecture, we discussed Starling equation, so please go ahead and review that. But in short, net filtration from any capillary depends upon the permeability of the capillaries multiplied by surface area and multiplied by the pressure gradient, of which there is a hydrostatic pressure gradient and oncotic pressure gradient. And net interstitial fluid accumulation will depend upon the amount of fluid that is filtered minus that removed by lymphatics. And if the amount of fluid coming from capillaries is more than what your lymphatics can handle, you will develop edema. So looking at this equation should give you a fair idea why there are differences between the rate of production of filtrate in various organs and their tendency to develop edema. So first thing first, different capillary beds have different permeability. From histology lectures, you should have remembered that there are three types of capillaries: continuous, fenestrated, and sinusoid. One of the things to remember is most of the fluid that leaks out of these capillaries are through the intercellular clefts. So if you look at zoomed in portion of a continuous capillary, most of it is tight junction, and there are slit pores between these tight junction with length around 200 to 400 nanometers and width around 14 to 20 nanometers with effective diameter around 8 nanometers. And size of albumin for comparison is around 7. However, there is another layer of complexity because all these cells are covered by glycocalyx, which changes the permeability of the membrane. The most important effect for differential effect of edema formation is gravity. Peak capillary pressure, which is the main driving force for your hydrostatic pressure gradient, is controlled very well on the arterial side by your precapillary sphincter. However, the venous side is unregulated, and this is the problem because the pressure in a vein depends upon the height of water column above it. So in a standing position, your right atrial pressures are around 0 to 5 centimeter of water. However, the pressure in the feet is the height of the total water column above it. So it approximates to around 100 centimeter of water depending on your height. And you can see there is a differential venous pressure throughout your body with more positive in most dependent areas, and it also becomes negative as you go higher than heart. So venous pressure at the end of capillary depends upon the height of water column above it and how effectively you can move that blood out of your venous system to reduce that pressure. So the venous blood flow to the heart is mostly passive. There is a layer of smooth muscles in the veins that may help squeeze some of the blood back, but it's not that effective. The most important way the venous blood flows to the heart is through the skeletal muscle contractions and one-way valves. So whenever you have contraction of the muscles, the blood in the veins is squeezed, and since it can flow only one way, it moves towards the heart. This is a graph of your venous pressure in the legs in patients with incompetent valves and normal. And you can see that patients with incompetent valves have pretty high pressures in the legs, up to 100 millimeters of mercury. While walking or doing calf exercise, this drops down to 25. And this is one of the reasons why patients with incompetent valves develop varicose veins, and why prolonged sitting or standing causes edema in the legs. Other two methods which help the flow of blood from periphery to the heart are arterial pulsations, since veins are in close proximity to the artery, as in vena comitans, and use of respiratory movements because you create a lot of negative intrathoracic pressure when you breathe. So the effect of gravity on venous blood flow is really important. As you get more dependent, your peak capillary is higher, so you get more filtration. So these tissues are more predisposed to develop edema. You can use the same principle when you treat these patients by elevating the organ to reduce edema or swelling. Interstitial hydrostatic pressure are different in different organs. Most of the skin and soft tissues have negative pressures, and that also includes lungs and joints. In the lung, the negative pressures are because of negative intrathoracic pressure, However, in skin and soft tissues and joint, the reason it is lower is because of the active movement of fluid from lymphatic beds. Encapsulated organs have much higher interstitial pressure, for example, kidneys, brain, and liver. Patients with burned skin have shown to have very negative interstitial pressure up to minus 20 millimeters of mercury, while patients with cancer have much higher interstitial pressures. And this is important because the lower the interstitial pressure, the higher the hydrostatic pressure gradient, so higher rate of filtration as compared to encapsulated organs. The compliance of interstitium is different in different organs. And in the previous lecture, you learned that as your interstitial pressure increases, your relative lymph flow increases up to 10 to 20 times. Encapsulated organs like brain, kidneys, and liver have low interstitial compliance, so any small increase in volume will increase their pressures, so increase their lymphatic flow. So this is one of the reasons why capsulated organs have more resistance to edema formation, because the interstitial pressure rise relatively more quickly with similar amount of fluid, so lymphatics increase their flow more quickly. This also explains one of the observations that you would have noticed, that renal failure in cardiorenal syndrome occurs much later in heart failure because tissue edema is much easier to form. Further, when you increase your interstitial pressure, you decrease your hydrostatic gradient. Therefore, you decrease the filtration. Next, different capillary beds have different permeability to proteins, and here we are talking about your sigma, that's your Staverman's reflection coefficient. To understand reflection coefficient, think about protein size and the pore sizes. So if the protein is larger than the pore, it will not be able to pass through that pore, so everything will be reflected back. So if sigma is 1, that means 100% reflection. So these are completely impermeable. If your sigma is 0.5, that means around 50% of the proteins can go through and 50% cannot. These are partially permeable membranes. If your sigma is 0, that means your protein size is much smaller than the pore size, and these are completely permeable. So different organs have different Staverman's reflection coefficient. Kidneys have highest around 0.99 and liver has the lowest around 0.1. This tells you that if your reflection coefficient is around 1, you will have higher oncotic pressure gradient, therefore low fluid formation. If you have lower reflection coefficient, your oncotic pressure gradient will be low, so you will have higher rate of filtration. So you'll notice that because of the low Staverman reflection coefficient, these organs can leak a lot of fluid. So you will see that these organs usually have low capillary pressures. For example, your pulmonary pressures are pretty low, and same are with the portal pressures. So that reduces your rate of filtration because your hydrostatic pressure is lower in these organs. Lower oncotic pressure gradient has two important clinical implications. First, the filtration in these conditions is completely dependent on hydrostatic pressure. That means if your sigma is very low, your component of oncotic pressure gradient is very low, so your net filtration depends mostly on your hydrostatic pressure gradient. Second clinical implication of this is if your reflection coefficient is very low, even if you want to increase your plasma oncotic pressure with albumin, it's not really going to help you that much, because even if you drive the oncotic pressure gradient very high, because of the low sigma, your net filtration will not change. So that means using albumin in patients who have leaky capillaries, for example in inflammatory edema, is not going to help you. Similarly, in tissues like lungs and liver, you will notice that because of the low sigma, your net filtration does not change. So that means these organs are not affected by your low albumin status. So these organs will not develop pulmonary edema or liver edema in cases of low albumin. Interstitial protein concentration differs in different organs. So organs like kidneys, which have almost no protein in their filtrate, versus liver, which has up to 6 gram per dl protein in their filtrate. So you can see that in liver, your oncotic pressure gradient is pretty low as compared to oncotic pressure gradient in kidneys. The concentration of protein in the interstitium will depend upon Staverman's reflection coefficient, as we talked previously, but it also depends upon the large pore transport system, which are the main way how the large proteins are transferred from plasma to your interstitium. And certainly it also depends upon the rate of dilution from filtration as well. When you talk about the modified Starling model in next lecture, you will figure out that why interstitial protein concentration may not have such a significant effect on the rate of filtration. Lastly, lymphatics are the vanguard of your filtration. So they increase their flow to accommodate the increased filtration. The lymphatics can increase their flow up to 10 to 20 times to accommodate that increase in filtration from the capillaries. Now we understand what are the different ways that these tissues differ in their edema formation tendencies. We can explain some of the commonly observed facts. So for example, in patients with cirrhosis, you have noted a lot of pitting edema and ascites, but you hardly note any pulmonary edema. And this is because these pulmonary capillaries have lower Staverman's constant and they have high interstitial oncotic pressures. So the capillary on the left is your capillary from the soft tissues compared to the capillary of the lungs on the right. One of the other things that you note is because your oncotic pressure gradient is low, you would expect high rate of filtration. However, in the lungs, plasma capillary pressure in the lungs are much lower than the plasma capillary pressure in your soft tissues. So let's look at the oncotic pressure gradient alone. Oncotic pressure gradient in a soft tissue capillary is around 18, while it's only 3 in the pulmonary capillaries. And let's reduce your oncotic pressure by half. And this results in your oncotic pressure gradient of 9 in your soft tissue capillary, and it certainly drops down to 1.5 in your lungs. You know that for every 1 millimeter change in pressure gradient, the filtration increases by around 6.6. So you can see that hypoalbuminemia will cause much more increase in filtration rate in a soft tissue capillary as compared to capillary in the lungs. To note, the oncotic pressure gradient decreases as capillaries become leakier, and smaller Staverman constant reduces the impact of oncotic pressure gradient. So in fact, your rate of filtration is now completely dependent upon the hydrostatic pressure gradient. So leakier the capillaries, lower is the tendency to develop edema due to hypoalbuminemia, and this is the same reason you don't get hepatic congestion in low albumin state. In summary, edema formation differs in different tissues because mostly effect of gravity on venous hydrostatic pressure. It also varies because of different interstitial hydrostatic pressure in different organs and different interstitial compliances. There's also difference in permeability to proteins and different interstitial oncotic pressures. We'll talk about individual effect of these in different organs in subsequent lectures. Thank you. These are the references.